we're going to go over the various spaces of the head and neck. And again, I'm going to make this incredibly simple because, part of the challenge about head and neck imaging, it's really all boils down to anatomy. And as you know, part of the department here at MSU, we're also in charge of anatomy for both medical schools. And I think there's some nice synergy there because I know when I was in medical school, we learned very little head and neck. And then as radiologists, we have this daunting experience to not only understand the anatomy, but understand its appearance on various types of cross-sectional imaging. So not only CT and MR, but when I started out, it was mostly just in the axial plane, and now you throw in sagittal planes and coronal planes. It just makes everything a little bit more complicated. So much of what we do is anatomy. So in my talk, I'm really going to be focused on the anatomy of the head and neck, and we're going to go over the various spaces of the head and neck. So we're going to go over all these spaces, and hopefully by the end of the next 40 minutes or so, if you're not really familiar with the head and neck anatomy and the spaces, I hope that you'll be able to translate this into your practice. In fact, you'll be so excited on Monday you're going to steal all the head and neck cases from your partners, right? That's what we hope will happen. Okay, so we'll go ahead and first start off with the first space, which is the masticator space. So pure and simply, the masticator space are the muscles of mastication. There are different components of the masticator space, but when we think about the masticator space, we really have to primarily concentrate on the muscles of mastication. So if I was to contour the masticator space, what I would end up doing is taking this little pointer like I am right here, coming around and making a little dip right here, coming across, coming over, and then coming back around. So when we look at the masticator space, the primary component of the masticator space are the muscles of mastication, which are the lateral pterygoid muscle, the temporalis muscle just medial to the coronoid process, and the masseter muscle, which is located here. Now, just inferior to the lateral pterygoid muscle is another muscle right here, which is the medial pterygoid muscle. So you can see the pterygoid muscles are one on top of the other. But the largest component of the masticator space by far and away are the muscles of mastication. The second biggest component of the masticator space are the bones here. Now these bones are essentially all attached to the mandible. So I just contoured the coronoid process, and here's the condyle of the mandible. Now when I was doing my contour, there was a little area right here that I went around, and that's the third division of the fifth cranial nerve. So the primary components of the masticator space are going to be muscle, bone, and nerve. And if you can understand those three components of the masticator space, this will give you a foundation of the various pathologies that will arise in the masticator space. So if we see something like this, here's a large mass involving the left masticator space, we know that the primary component of the masticator space is muscle. So when we see something this large, the most likely diagnosis is going to be a sarcoma. In this case, this happened to be a synovial cell sarcoma. Now, how do we know it's in the masticator space? Well, pure and simply, what I do is I try to put my finger or my pointer in the middle of that space, and then I take it over on the opposite side and try to find the center on the opposite side. We can also look in this area here. Here's the parapharyngeal space that we'll talk about later. Notice how this is intact, and you can see how the parapharyngeal space is displaced medially. So by demonstrating that this mass is in the masticator space and is separate from the parapharyngeal space, then we can accurately localize the mass to the masticator space. Another example here, here's a mass primarily involved in the masticator space. We can see this is bleeding over a little bit in the parapharyngeal space, and it's encasing the carotid artery. We'll talk about that a little bit later. But again, you can see primarily this is arising in the masticator space. And again, this was another form of sarcoma. This is another masticator space mass, and now we get into those crazy jaw lesions. So here's a large osteoma that's arising from the condyle of the mandible, and here's an expansile lesion involving the ramus of the mandible, and this happened to be, anybody want to take a guess? It starts with an A. Ameloblastoma, exactly right. Those are some of those crazy jaw lesions. But again, in a way, the pathology is not important in this talk. The main thing is to properly identify that the pathology that we're seeing is in the masticator space, and then we can come up with an appropriate differential diagnosis. In this case, this was a mass that was involving the masticator space, but it very nicely demonstrates that you can see this muscle right here, which is a lateral pterygoid muscle, which is displaced laterally. And we can see if it's displaced laterally, then the mass has to be arising just medial to the pterygoid muscle. So here's a pterygoid muscle here. There is this structure right here, which is oval shaped. That's actually V3. So in this particular case, the lateral displacement of the pterygoid muscle laterally suggests that this may be arising from the third division of the fifth cranial nerve. And then when we look at the coronal images, we can see this mass extending superiorly through foramen ovale, which confirms the fact that we're looking at a schwannoma arising from the third division of the fifth cranial nerve. So that's the masticator space. Remember, the three primary components are muscle, bone, and nerve. And if we can properly identify it, then we can come up with a solid differential diagnosis. The next space is the visceral space. And you know, the great thing or the bad thing about head and neck radiology is that we take the same piece of anatomy and we just give it different names. So for instance, the actual name of the fascia here that I'm contouring, I use the term visceral fascia because this was the original term given in the classic articles on the spaces of the neck, space of the head and neck written in 1937 by Grudinsky and Holyoake. So I tend not to change the names. But having said that, as we have involved, this fascia now has different names to it. Some people will call it the pharyngomucosal fascia. Some people will call it, whatever. There are numerous names to it. But I just call it the visceral fascia. And if you call this the visceral fascia, then the next space is very, very easy to identify because the name of this space is the visceral space. So how do you identify the visceral space? Well, what you do is you look in someone's mouth. So if you look in someone's mouth and you do endoscopy, direct or indirect endoscopy, everything that you can see in that patient's mouth is in the visceral space. So sometimes this space is referred to as a pharyngomucosal space. So because it's in the pharynx and it contains mucosa, it's called the pharyngomucosal space. But again, I tend to use the term visceral space. Now, the visceral space, here's another example here of the visceral fascia, and everything that's enclosed here is in the visceral space. So these are just some examples of visceral space masses. And again, what do you think the most common malignancy is going to be involved to involve the visceral space? Squamous cell carcinoma. Yeah, number 1, 2, and 3. But in general, when we see masses that are involving the pharynx or the visceral space, the most likely malignancy is going to be squamous cell carcinoma. But on the other hand, one of the lessons that I learned many years ago in my fellowship is that if you see a mass that's involving the visceral space, you don't need to give a huge differential diagnosis because sometimes as radiologists we get a lot of joy saying, well, I can name 10 things that this could be. In actuality, when something's in the visceral space, the ENT surgeons can look directly at this mass and do a biopsy, and they can tell you the diagnosis. What we really need to be able to do is provide information that they cannot see on their clinical examination. So to reiterate this point, yes, this could be squamous cell carcinoma, but this was actually metastatic adenocarcinoma. Now, there's no way we can make that diagnosis. But what we need to be able to say that the mass is in the visceral space, comment on potential spread patterns, look for deep extension. That really is the job of the head and neck radiologist. Now, this is another, and I'm not going to say necessary an abnormality, but it's one of those potential pitfalls that we see. So we see this mass here involving the visceral space. It looks pretty large, right? And if I told you that this was a child, well, this is just a normal finding. This is just adenoidal hypertrophy in a kid. And these are just retropharyngeal lymph nodes that are slightly enlarged. Remember, kids can have enlarged retropharyngeal lymph nodes. But if you see something like this in a child, realize it's probably not, in the majority of cases, an aggressive nasopharyngeal carcinoma or a rhabdomyosarcoma. It just tends to be adenoidal hypertrophy. The other thing that tells us it's not malignant is that something this big eventually should creep through laterally through the visceral space to involve the adjacent muscles and the adjacent fat. And in this case, everything is confined to the visceral space. So this was just adenoidal hypertrophy in a child. And I think we can all make the diagnosis here. Here's a cystic mass that's located between both longus coli muscles in the pharyngeal bursa. Anybody want to shout this out? Starts with a T. Torn wall cyst, exactly right. So why does this make a difference? It makes a difference because we can see that this torn wall cyst is anteriorly displacing the overlying mucosa. So this is a submucosal mass that's causing some mass effect. So our ENT surgeons may see this submucosal mass, but they may not be sure what the exact etiology is. So we can say that there's a submucosal mass, it's cystic, and we can confirm the diagnosis that this is not ominous, rather that this is just a torn wall cyst. Okay, so the next space that we'll talk about is the retropharyngeal space. Now, it's pretty simple that this space, we just talked about the visceral space, so the other name for the visceral space is essentially the pharynx. So what do you call the space that's located behind the pharynx? Well, that's why it's called the retropharyngeal space. So if we look here, here's the visceral fascia that we just talked about, which encloses the visceral space. Now, there's another fascial layer, this dotted line right here, which is referred to as the pre-vertebral fascia. And again, this name has evolved over time. I think some people now call it perivertebral fascia. It's essentially the same thing. But the original name given to this is the pre-vertebral fascia. So that's the terminology that I use. So essentially in a general practice, I think if you can say that there's air here that's located behind the pharynx and that's located between the visceral fascia and the prevertebral fascia, and you can say that this is the retropharyngeal space, then to be honest with you, I think you're doing just fine. But for the aficionados out there, if we look more closely at the anatomy behind the visceral fascia but anterior to the prevertebral fascia, there's a dashed line right here which represents a very thin fascial layer that starts with an A. Anybody want to shout it out? Alar fascia, exactly right. So that's the alar fascia. So the true retropharyngeal space is located between the visceral space and the alar fascia. So these lymph nodes right here are located in the retropharyngeal space. And the space that's located between the alar fascia and the prevertebral fascia is another small space. Anybody know the name of that? Starts with a D. The danger space, exactly right. So there actually are two components, if you will, in this area. So the most anterior one is the retropharyngeal space, and the posterior one is a danger space. Now this space, the true retropharyngeal space, extends down into the mediastinum and terminates somewhere between T2 and T6. But the danger space extends all the way through the mediastinum, through the crura of the diaphragm, and is continuous with the retroperitoneum. And the way the spaces were first diagnosed, actually, or identified, were these French anatomists that were doing these dissections and trying to figure out in the late 1790s why patients that had infections in the head and neck could end up dying of abscesses involving the chest or the abdomen. And this was the answer. And that was the original individuals that first looked at the spaces and identified the spaces. So the spaces were not created to torture boards on your residents on your boards. Believe it or not, it's hard to believe. But in actuality, they were first identified to figure out why patients that had infections in their head and neck could somehow die of these terrible diseases. So what are some pathologies that can involve the retropharyngeal space? Well, this was an interesting thing. We always have to be aware of this. On the patient's right-hand side, there's a carotid, there's a jugular vein. Here's a jugular vein, and this is a carotid artery that's wandering into the retropharyngeal space. Now, why is this important? Because this patient was pre-op for a tonsillectomy. The surgeon thought that the patient may have a wandering carotid artery, so before they did the tonsillectomy, they did the CT scan to look for the location of the carotid artery. And lo and behold, there is the carotid artery in the visceral space. This is another example of a pathology involving the retropharyngeal space. This is a classic metastatic retropharyngeal lymph node. I think we'll talk about this later when we talk about lymph nodes. But here's the carotid artery, here's the jugular vein, and there is the retropharyngeal lymph node just lateral to the carotid artery. And this is not a true retropharyngeal abscess. This is actually a suppuration or liquefaction or liquefaction of a retropharyngeal lymph node. So when I started out years ago, we would always call these retropharyngeal space abscesses. But when you see something that's this rounded, just medial to the carotid artery, that's lateralized like this, that doesn't cross the midline, in a patient that has infection, the true diagnosis is suppurative retropharyngeal lymph node. And the reason that's important is that now these patients, if we see this radiologically, the patients can be successfully treated with broad-spectrum antibiotics. This is a true retropharyngeal space abscess. As I mentioned before, the retropharyngeal space ends between T2 and T6. And in this particular case, we can see the abscess here in the retropharyngeal space. And when we look down in the mediastinum, we can see that there's actually a mediastinitis and a mediastinal abscess. And the way the infection gets from this area into the mediastinum is through direct extension of the conduit of the retropharyngeal space. Okay, now let's move on to the next space, which is a pre-vertebral space. Now, oftentimes when I give this talk, I'll ask the residents and I'll say, how many of you have ever seen a pre-vertebral space mass? And nobody raises their hands. And it's always fascinating to me. And then I said, how many of you have ever looked at a spine CT or MR? And then everybody raises their hand. So the point being is that the pre-vertebral space encompasses the longus colli muscle and essentially the vertebral bodies. So when we look at the anatomy of the pre-vertebral space, what this really encompasses are the vertebral bodies, including the clivus, C1, C2, C3, and C4. We also look at the various longus colli muscles, and we also have the vessels that run laterally to the vertebral bodies, and those are the vertebral arteries. So the thing about head and neck is that if you think of this as a pre-vertebral space mass, then everyone says, oh, that head and neck stuff, I hate it, I never see that stuff, whatever. But on the other hand, if we just pivot that and we say that, have you ever seen something in the spine, then all of a sudden you can come up with a very robust differential diagnosis. So this is just a couple of examples of pre-vertebral space masses. This is a true retropharyngeal space abscess, and we can see that's extending posteriorly, and it's extending between C1 and C2. And if we look closer, we can see that this prevertebral abscess is extending all the way into the spinal canal, resulting in an epidural abscess. This, on the other hand, is one of the classic findings of a prevertebral space mass. And again, if I put on my neuroradiology hat, I'm just going to say a cervical spine mass. But here we can see relative preservation of the cervical spine in a patient. Let's just say they came from India or South America. What do you think the differential would be here? TB, exactly right. So this is tuberculosis with Pott's, otherwise known as Pott's disease. Now here is one of those, if you will, head and neck masses that's kind of unique to the head and neck. So if I tell you here there's this aggressive mass that's arising at the top of the vertebral body, located just below the clivus, it enhances with contrast, but on T2 weighted images, it's high signal, indicating that it's a little bit more mucoid containing. Then anybody want to take a guess at what this diagnosis is? Chordoma, exactly right, perfect. So this is one of the unique things. But realize when we are talking about prevertebral space masses, yes, we sometimes think of chordomas, but in your practice, the most common prevertebral space mass is going to be a disc bulge, a disc herniation, some type of degenerative disc disease, metastases, myeloma, the stuff that you normally think about when you're looking at the cervical spine. So when you think of the prevertebral space lesions, those should be at the top of your differential diagnosis. It shouldn't be the rare birds like chordoma. And this is just one other example here. This was turned out to be a plexiform neurofibroma involving the clivus, but the diagnosis is not important. What's really important that you identify that on the right-hand side of this patient, there's normal signal involved in the clivus, and this lesion is completely replacing the clivus. So the key thing is isolating these lesions into the prevertebral space. Because once you identify in the prevertebral space, then you can come up with your differential diagnosis. Another example here, if I told you that this patient was involved in trauma, this is a prevertebral space mass. If I told you there was trauma and they presented with acute vertigo, what do you think the diagnosis is going to be here? Dissection, exactly right, involving the vertebral artery. Notice the narrow caliber on the left side compared to the right side. All right, so the next one is really easy, right? So let's review a little bit, right? Masticator space, right? Muscles of mastication, bone, muscle, and nerve, right? Visceral space, anytime that you look in someone's mouth, everything that you see is in the visceral space. The retropharyngeal space is that space that's located just behind the pharynx. The prevertebral space, in other more common terms, is the cervical spine and everything that surrounds the cervical spine. And this one's really hard, right? The next space is just pure and simply the parotid space. So everywhere that you see the parotid gland, you'll see the parotid space. So if I had to contour the parotid gland, this is where I would be contouring the parotid gland here. Again, just to review, what space is located here? Masticator space? Good. What's the potential space that's located here? Potential space. Yeah, retropharyngeal space, danger space, that's fine. Then what space am I contouring right here? Pre-vertebral space, exactly right. So when we look at the parotid space, again, I'm going to contour the parotid space on the opposite side. Everyone knows where the parotid gland is. But what we always have to be aware of the parotid gland is there's a certain nerve that's associated with the parotid gland. What nerve is that? The facial nerve. So here's a patient that underwent a superficial parotidectomy, and we can see the various branches beautifully laid out in the facial nerve. And the facial nerve separates the parotid gland into a superficial and a deep lobe. So how do we identify the location of the facial nerve? Well, what we do is we look at the retromandibular vein, which is located right here, and the facial nerve is located just lateral to it there. So there's our facial nerve. So the facial nerve separates the parotid gland into a superficial lobe and a deep lobe. And on the right-hand side, there is the facial nerve, and you can see it's in a plane, and the superficial lobe has been removed, and everything deep to the branches of the facial nerve are located in the deep lobe of the parotid gland. So what are some pathologies that involve the parotid gland? Well, here's a pathology that involves the parotid gland. Here we have multiple lesions that are located in the tail of the parotid gland. They're bilateral and they're multiple. And so what do you think the most common diagnosis is going to be here? That's exactly right. It's a Warthin's tumor. So, what's a Warthin's tumor, and why are Warthin's tumors typically in the tail of the parotid gland, multiple, and oftentimes bilateral? And the reason is that the other name for Warthin's tumors, it's called cystadenoma lymphomatosum. So what does that mean in English? Because that's a Latin term. Just remember that the parotid gland has multiple lymph nodes. And those lymph nodes can be at the pretracheal region. They can be around the capsule of the parotid gland. They can be along the facial nerve or the tail of the parotid gland. So lymph nodes can be multiple. In fact, they are multiple in the parotid gland, and they're bilateral. So cystadenoma lymphomatosum indicates that the Warthin's tumors arise from some embryonic remnant of lymphoid tissue. And the lymphoid tissue in the parotid gland tends to be in these lymph nodes. So that's why Warthin's tumors can be multiple and bilateral and have a propensity to arise in the tail of the parotid gland. So I know I've got a couple of fellows out there. We've seen a couple of probable cases of Warthin's tumors. And that's why when we see something in that region, that's why we suggest the diagnosis of a Warthin's tumor. Now, this was a diagnosis that we used to make 20 years ago when I was a fellow. If I told you that this patient was HIV positive, then what's the diagnosis that we see here? Anybody? I remember 20 years ago, everybody would get this diagnosis. Yeah, lymphoepithelial cysts, exactly right. These are lymphoepithelial cysts. So back when I was a resident, a fellow, this was in the AIDS era. And a lot of patients would come in with a triad of head and neck findings with HIV. And they were the presence of lymphoepithelial cyst, all of these multi-shoddy lymph nodes, and then prominence of the adenoidal tissue involving Waldeyer's ring. We don't see this as much anymore. I think, fortunately, we've got a much better handle on AIDS, and there's been tremendous success with triple therapy. But if you do see multiple cysts like this, these are lymphoepithelial cysts. Now, oftentimes when I show it to this generation of residents, they'll say, well, it's multiple Warthin's tumors. Because if you read the books, they say Warthin's tumors have cysts. Well, the cysts in the Warthin's tumors aren't big balloons like this, like big water balloons. You can have little focal cystic areas in Warthin's tumors, but rarely have I seen Warthin's tumors that have been this cystic. So when I see cysts that are this big, then I start thinking of lymphoepithelial cysts. And one of the main things when we look at head and neck imaging is, as I mentioned before, the real value that we have is not only to identify that there's a mass there and potentially look for, if you will, more malignant findings, but really trying to determine whether it's involving the superficial lobe or the deep lobe. Because a superficial parotidectomy, the surgeons do not have to go deep to the facial nerve. Whereas if we say the tumor's involved in the deep lobe of the parotid, then the surgeons have to either dissect or potentially sacrifice the facial nerve in order to remove the full extent of the tumor. So this is just an example of lesions, in this case involving the superficial lobe. So here's the mass involving the superficial lobe of the parotid gland. Here's the retromandibular vein. So our facial nerve is about at the tip of the arrow. But in this particular case, we can see this mass is deep to the retromandibular vein, deep to the facial nerve, and extends deeply to involve the parapharyngeal space. So if you will, this is where, again, we earn our value, because we can then help direct the surgical management. Because if we do say the mass is involved in the deep lobe, then these patients have to undergo a total parotidectomy, where if it was isolated just to the superficial lobe, then they can just undergo a superficial parotidectomy. Here's another example of where we earn our value in head and neck. Here's an aggressive lesion involving the right parotid gland. Now, if you look at the parotid gland, these tumors can grow deeply and extend between the styloid process and the mastoid bone in the stylomastoid foramen. And with a leap of faith, if you look right at my arrow, there's a dot right there. That's actually the facial nerve in the stylomastoid foramen. So anytime that we have tumors involving the parotid gland, these tumors then can extend deeply to the skull base. And because the facial nerve is located in the parotid gland, we should be performing MRs to determine whether or not there's retrograde perineural extension along the facial nerve. Now, the fact of the matter is that 9 times out of 10, the surgeons are going to know whether or not the patients have a malignancy of the parotid gland. Why? Because the facial nerve is already out. So our job is not necessary to give, again, a litany of a large differential diagnosis. What we need to be able to tell our surgeons is whether or not there's retrograde perineural extension. Because if there's no perineural extension, then the surgeons could potentially just do a total parotidectomy. But if there is retrograde perineural spread along the descending portion of the facial nerve, then these patients would either have to have their mastoid drilled out to remove the facial nerve, or if it's very extensive, then they would just potentially be treated with non-surgical organ preservation therapy. So really, that's the value of imaging. You know, now we're in the value era of radiology, so we have to emphasize the value that we provide to these patients. So the next area is pure and simply the parapharyngeal space. So let's go ahead and review, right? Repetition is good, right? So what space am I looking at here? Masticator space. Which space is here? What space is located right here? Yeah, retropharyngeal space. What space is located here? Pre-vertebral space, perfect. What space is located here? Parotid space, exactly right. Now we're going to look at the space that's next to the pharynx. So what do you call the space that's next to the pharynx? Parapharyngeal. Isn't head and neck easy, right? If you want something really hard, do mammography or something like that, right? Do mammo. I have no idea what that is, right? CCs, I have no clue. So anyway, yeah, the parapharyngeal space is located just adjacent to the pharynx. And, you know, to be honest with you, there's not a lot of pathology that arises in the parapharyngeal space. But I'll tell you just a couple of things to remember. The most common pathology to involve the parapharyngeal space is this pathology here on your left-hand side. And this is deep spread of squamous cell carcinoma. See how this tumor is extending deeply into the parapharyngeal space. So that's the most common tumor to involve the parapharyngeal space. But the most common tumor to arise within the parapharyngeal space is this pathology here. And this is a pleomorphic adenoma. So the minor salivary gland tumors are the most common pathology to arise in the parapharyngeal space. So I'll just toss this out to you. Again, like, I'm not the smartest tool in the shed. It takes me a long time to get things. I never did understand what a minor salivary gland tumor was, because I would think, you know, what is a minor salivary gland tumor? Well, what a minor salivary gland tumor is that you take the same constituent histology that comprises a major salivary gland, which is the parotid gland or the submandibular gland, and then you place that in an area where it shouldn't be. So if I take this type of salivary tissue and put it in the parapharyngeal space, and then you have tumors that arise from that same tissue. So the same tumors that can arise in the parotid gland can now arise in the parapharyngeal space. That's why we call it a minor salivary gland tumor. So the fact of the matter is, these are the same types of tumors that occur in the major salivary glands. It's just that these tumors they're now arising outside of the major salivary gland. So that's why it's called minor salivary gland tumors. And the most common, as you know, the benign ones are Warthin's tumors and pleomorphic adenomas, and the malignant ones are adenoid cystic and mucoepidermoid carcinoma. So in this particular case, the most common tumors to arise in the parapharyngeal space are going to be minor salivary gland tumors. Another example here, this is another pathology involving the parapharyngeal space. And again, I want to emphasize that in this case, the pathology is not important. I don't know if anyone can guess. This is a benign lesion that's cystic and has a fluid level. Anybody want to take a guess? A benign lesion? Anybody? Lymphangioma, yeah, exactly. Lymphatic malformation, cystic hygroma, exactly right. But the key thing here is, how do we know that this is involving the parapharyngeal space? Well, the reason is that if we look at the carotid artery here, the carotid artery is displaced inferiorly. Excuse me, let me say that again. If the carotid artery is displaced inferiorly, then we know it's in the parapharyngeal space. And here we can see the carotid artery has been displaced inferiorly, so that tells us it's in the parapharyngeal space. We'll see later what happens if the carotid artery is displaced anteriorly, because anterior displacement of the carotid artery tells us it's in a different space, and we're in a completely differential diagnosis. And so the next space is this space that involves the carotid artery. So let's go through our spaces again. So what space did we just talk about right here? What space is located here? Parapharyngeal space. The space that we're going to look right now is the carotid space. This space was the masticator space. This space was the parotid space. This space was the visceral space. And back here is the retropharyngeal space, right? So we're putting the pieces of the jigsaw puzzle together, right? All of a sudden, it's all starting to make sense. So what are the components of the carotid space? Well, the carotid space contains the carotid artery, the jugular vein, cranial nerves 9 through 12, and also the various lymph nodes. So again, you know, essentially all those components, an artery, a vein, lymph nodes, and the nerves arise everywhere else in the body. But again, once we get to the head neck, it starts, head neck is really hard, right? But take these anatomic structures and give it the same differential diagnosis you would in other parts of the body. So for instance, here's a carotid space mass, right? So what's the diagnosis for this very large carotid space mass? It's what? It's an aneurysm, right? Here's another carotid space mass. This patient had a prior history of a central line. So we can see the jugular vein, the carotid artery, and what's this? Thrombosis of the jugular vein, exactly right. Again, a carotid space mass. Here's another carotid space mass, or carotid space abnormality. So here's the carotid artery. Here's the carotid artery. The patient had trauma. So what is this right here? A dissection, exactly right. Dissection involving the carotid artery. The previous dissection I showed involved the vertebral artery. This was involving the carotid artery. And on this gradient echo image, here you can see the very, very narrow lumen of the carotid artery, and there's the surrounding methemoglobin. Now, this is the classic carotid space mass, and I'll spend a little bit of time on this because the most important area in this region, the identifier, the indicator, is the carotid artery. So here's our carotid artery here. And anatomy. If we can understand the anatomy, then we will be able to properly identify the space in which the mass is located. And once we identify the space, then we'll be able to come up with a differential diagnosis. So I mentioned before, if the carotid artery is displaced inferiorly, what space is it in? Parapharyngeal space. If the carotid artery is displaced medially, then what space is it in? Parotid space, right. If the carotid artery is displaced laterally, then there's going to be a mass pushing here. So what spaces could that mass be in? Retropharyngeal space or pre-vertebral space. And if the carotid artery is displaced anteriorly, then what space is the mass in? Nope, carotid space, right? Because the pre-vertebral is going to shift the carotid artery to the right-hand side because the pre-vertebral space is going to be in here. So In this particular case, we can see that the carotid artery is displaced anteriorly. So what space is this mass in? Carotid artery. In this particular case, the carotid artery is displaced anteriorly. So what space is this mass in? Same thing, right? Carotid artery. So internally, what's the difference between this area and this area? What do we see here internally that we don't see on this side? What are these guys right here? Somebody said it, flavoids, right, vessels, right. So both of these are carotid space masses. On this one, on the right-hand side, they're flavoids, and on the left-hand side, they're no flavoids. So what do you think the diagnosis is here? What's that? Carotid, well, a glomus tumor, yeah, some type of glomus. I'll go over the various types of glomus tumors. And what do you think the diagnosis is here? Benign lesion, schwannoma, exactly, a neurogenic tumor. So the classic, once you get into this area in the carotid space, if you see a benign, a very bland lesion, no flavoids, that's in the carotid space, then you think of schwannoma. You see a similar sized lesion with multiple flavoids, then you think of glomus tumors. Now, why is that important? Because if we, the radiologists, say that this is a glomus tumor, then the patients are undergoing some type of vascular imaging. Whether it's CTA in this day and age, in the old days, we used to go straight to angio. But if we tell the surgeons that this is a schwannoma, then they're going to go to surgery, right? So on the other hand, if we tell the surgeons that this is a schwannoma, then what's going to happen? They're going to be pissed, right? They're going to be pissed because they're going to go in and they're going to be scooping out buckets of blood, right? So that's why it's very important, because this is a clinically blind area. It's deep to the tonsil, it's deep to the mandible, it's deep to the parotid gland. It's in a clinically blind area. So again, when we talk about the value of imaging, this is what we really provide. So here's an example. Again, a carotid space mass. And notice how there's no flavoids. This is a schwannoma. And just to prove it, we did, this just happened to be, let's see, there we go. There we go. There's the MRA. You can see there's no flavoids in this at all. This, on the other hand, a CTA, we can see a diffusely, densely enhancing lesion involving the carotid space. This is, again, a glomus tumor. And we'll go over the different types of glomus tumors. And on MR here, we can see the carotid artery displaced anteriorly, multiple flavoids within it. Again, this is a glomus tumor. So if we have a glomus tumor that arises between the carotid arteries and separates the internal and the external carotid arteries, this is a carotid body tumor. And this is the same patient just after embolization. You can see that the carotid artery are separated. The internal and the external carotid arteries are separated. So this is a carotid body tumor. This, on the other hand, you can see that the internal and the external carotid arteries are pushed together. So when the internal and the external carotid arteries are pushed together, that means the mass has to be extrinsic. So this is what's referred to as a glomus vagale tumor. And these arise from the nodose ganglion. If you have the same tumor that then arises from the skull base, then this arises from the superior cervical ganglion, and this is what's referred to as a glomus jugulare. So the glomus tumors are the same pathology, but it's just given the different names based on the location. So a glomus tumor at the carotid body is a carotid body tumor. A glomus tumor in the neck that compresses the internal and the external carotid arteries, that is a glomus vagale tumor. A glomus tumor that arises from the jugular foramen, that's a glomus jugulare. And to complete it, what do you call a glomus tumor that arises in the middle ear cavity? That's a glomus tympanicum tumor. And, all right? Well, the last two spaces, again, are pretty straightforward. In order to understand the last two spaces, how many people in the audience majored in the classics? Nobody. It's terrible. How many were biochemistry or science majors? How many didn't go to college but ended up going to med school? Okay, all right. Hey, the person that raised their hand, you're the same person that came in. You just came in for the free food, right? Is that right? Okay, yeah, I thought so. Right. So again, as I mentioned before, the thing about head and neck is that we take the same piece of anatomy and then we change names. I mentioned, as I said before, and we do the same things when we talk about this next area, because we're now going to talk about the sublingual space. And pure and simply, the sublingual space is the space located below the tongue. So lingua is Latin for tongue. So that space that's located below the tongue is in the sublingual space. So what forms the sublingual space? Well, the roof of the sublingual space is formed by the tongue. The lateral rim of the sublingual space is formed by the mandible. The rim or the wall of the sublingual space is formed by this muscle right here, which anybody want to take a guess what that muscle is? Mylohyoid muscle. And then the base of the sublingual space is formed by this bone right here, which is what? Everybody knows that, right? It's the hyoid bone. We'll talk about that later. But essentially the way I look at it is that if this is the anatomic images, here's the top of the tongue, here's the mandible, here's the mylohyoid muscle, and here's the hyoid bone. So to me, it looks like a teacup. So essentially, the rim of the teacup is formed by the mandible, the wall of the teacup is formed by the mylohyoid muscle, the base of the teacup is formed by the hyoid bone. So everything within that teacup is essentially within the sublingual space. But here's where the challenge comes in. So these muscles that run from the mandible all the way back to the tongue base are referred to as the genioglossus muscle. So why glossus? Well, glossus is actually Greek for tongue. So even when we talk about the sublingual space, we flip our roots. So lingua is Latin and glossus is Greek. So the muscles are based on the Greek roots, but the space itself is based on the Latin roots. So what are some pathologies that involve the sublingual space? Well, the most common tumor that we see is going to be squamous cell carcinoma. So here's a schematic illustration, and on the right-hand side, here's a T1 weighted image with contrast demonstrating a squamous cell carcinoma. Now, these are very nonspecific. This could be squamous cell carcinoma. This could be any type of malignant minor salivary gland tumor. So for us, we can't really say much about this specific histology. So we really do leave it up for the surgeons to biopsy it and the pathologist to come back and give us the diagnosis. But 9 times out of 10, the pathology is going to be squamous cell carcinoma. This, on the other hand, if I told you the patient had a fever, what are we going to say that this is? Sublingual space abscess, and here is the rotten tooth. So here we can see the rotten tooth, we can see the sclerosis. Back when I was a resident, we used to call this sclerosing osteomyelitis. Now, the classic thing that was always described for the head and neck was actinomycosis. I think this was just a bacterial sublingual space abscess. But if you're taking your boards or whatever and they say, well, what's a pathology involving the mandible that can result in a chronic osteomyelitis, the diagnosis tends to be actinomycosis. And this is a mass that's involving a cystic mass anteriorly and midline. This is an epidermoid. If this same lesion was in the tongue base, then this would be a thyroglossal duct cyst. In this case, we have a cystic lesion involving the lateral aspect of the sublingual space. This is a ranula. So ranula here, epidermoid here, and if there was a cystic mass involving the tongue base, then that would be a thyroglossal duct cyst. Now, ranulas can involve the sublingual space, and they can eventually extend down below the mylohyoid muscle. So if we say that this bilateral ranula is contained as it is here by the mylohyoid muscle, then this is what's referred to as a simple ranula. And the surgeons can go in through an intraoral approach and marsupialize the ranulas. So it's pure and simply, it's a pretty easy procedure. But as we'll see later, if the ranulas extend deep to the mylohyoid muscle, and we can identify that on imaging, then all of a sudden it changes how the surgical approach to these lesions. And the last space that we'll talk about is the submandibular space. Now this is very easy, right? So what do you call the space that's located below the mandible? Now real quickly, because I still have a couple of minutes left, I'm going to ask you again real quick. What space am I looking at right here? Masticator space, perfect. What space am I looking at right here? Sublingual space, exactly right. So when you look at the submandibular space, it's all of this space here that's located below the mandible and below the mylohyoid muscle. So what are the components of the submandibular space? By far and away, the largest component of the submandibular space are going to be the lymph nodes. So the lymph nodes are located in the submandibular space. These are what's referred to as the level 1 or the group 1 lymph nodes. The second most common thing that you'll see is pathology involving the submandibular gland. So remember, the submandibular gland is located in the submandibular space. However, the duct of the submandibular gland, which is referred to as Warthin's duct, extends superiorly and runs along the mylohyoid muscle and eventually runs in the sublingual space. So this is an example of enlargement of the submandibular gland. Here we can see dilatation of the submandibular duct or Warthin's duct. And the reason why this is obstructed is due to what? What's this right here? Anybody? It's a little stone. It's a little sialalid. So this is what's referred to as an obstructive sialadenitis, and the cause for the obstruction is the stone that's located in the sublingual space. So remember that communication of the submandibular gland with eventually where the submandibular duct extends out into the frenulum. And another example here, this was a tough case. Here we have enlargement of the left submandibular gland. Now, this was a case that came a few years ago. This floor of mouth CT is the exact same patient that's associated with this. So this is a little bit subtle, but you can make the diagnosis if you know where to look. So here's a submandibular gland. Here's the genioglossus muscles. Here we can see enhancement of the lingual arteries. Here's the normal sublingual space. Notice the fat here. Notice how the fat's obliterated on the left-hand side. And the frenulum is located right at the tip of my pointer. So the reason this patient had obstruction of the submandibular gland is because this squamous cell carcinoma was actually occluding the submandibular duct as it was coursing through the sublingual space. Okay, so anytime, the bottom line is anytime that you have obstruction of the submandibular gland, you have to take a very close look at the sublingual space to make sure there's no stone or to make sure there's no aggressive lesion that's causing the obstruction of the gland. And the last thing that we'll talk about is that here is another ranula, right? A little cystic lesion involving the lateral aspect of the sublingual space. And look how this ranula is now extending into the submandibular space. Remember I told you before in head and neck we take the same piece of anatomy or the same process and give it different names. Well, this type of ranula that extends deep to the mylohyoid muscle has 3 names to it. And that's why people get confused. Anybody remember the 3 names to this? Diving is 1, plunging is 2, and if it's simple, then you have complex. So the 3 names for this type of ranula that extend below the mylohyoid muscle are diving, plunging, or a complex ranula. But it is important because if you say that the ranula is extending below the mylohyoid muscle, then the surgeons cannot do an intraoral approach, but rather they have to do a cervical approach. So again, this type of pre-surgical planning is again based on what we say on imaging. So in summary, what I've tried to do over the last 45 minutes is give you a simplified approach to the space of the head and neck. Remember the masticator space, muscles of mastication. Visceral space, as the day goes on and you start to yawn, remember everything that you can see in someone's yawn is the visceral space. The retropharyngeal space is just behind the pharynx. The pre-vertebral space is the spine. Parotid space is self-explanatory. The parapharyngeal space is just next to the pharynx. The carotid space contains the carotid artery. The sublingual space is below the tongue, and then that space below the mandible is the submandibular space. So thank you very much for your attention.